Good afternoon, everyone. Thank you for joining us today for the One Houston Together webinar series. This is our third one of the month. We have been hosting one every Tuesday through September. So for those of you who have been able to join the last two, thank you very much for sticking in, or if you guys have been able to catch the recordings that have been posted on our website, thanks for viewing those as well. And I hope those conversations have been helpful in your own journey on understanding racism, understanding the implications of that and disparities and how we can create a more equitable Houston. So the first webinar was on understanding racism. So very much a foundational conversation. Last week's was on education and racial inequities in that system. And then today we're focusing on health. And it's intentional that we are saying health and not health care. Just that, research has shown that in terms of an individual's outcomes related to health, about 20% of that is related to the care that you receive from what we would consider our traditional healthcare system. So your doctors or hospitals, et cetera. And then the 80% is what a lot of the experts who are on our panel today would call the social determinants of health. And that covers your surroundings, right? How accessible are healthy foods to you? Do you have ways that you can exercise? Do you have environments that allow for good air quality? So all of those factors contribute to your overall health outcomes. So today is really looking at the ability to address equity and being able to look at that full 100% of health for an individual and for a community. So I'm really excited to welcome our panelists and our moderator. I will go through their names and titles quickly so we can jump into the conversation, and the bios will actually be in the chat screen. So if you want to click through, you can look at that too. First, we have Zawadi Bryant, who's the CEO and founder of the NightLight Pediatric Urgent Care. As our first panelist, the second panelist, Dr. Leclerc Raphael, who's the associate professor at the Baylor College of Medicine, and Elena Marks, who's the president and CEO of Episcopal Health Foundation. Our moderator today is Tanweer Kaleemullah with the Harris County Public Health as their public health policy analyst. And for those who recall, earlier in this year, Harris County had released the Harris County findings, and it's just an incredible data set, very rich with information that has layers of geographic disparities, just really great information there, and we'll share a link out to that as well. So without further ado, I'll kick it over to Tan to have the conversation with our panelists. Thanks, everyone.
I'll wait for everybody's video to start and we'll get started. And thank you, Jenny, very much. And thank you to the Great Houston Partnership. This is a great series. I was able to tune into the one last week on education, so I do recommend for people who did not get to watch that to go watch that. So this is, I think, set to be a really good discussion. We have a really good group of panelists here with a lot of rich experience and knowledge. And so I think we're going to have a good discussion, but also just to make sure everybody understands, this topic probably deserves at least 1 to 2 semesters of class by itself. So we're not going to be able to solve the world's problems in this hour. But yeah, we're going to have, like I said, a good discussion. At the end of the question portion, or we're going to ask the panelists also to recommend a book or two, just to kind of help people to have something to take away, because there's a lot of really good books out there to help further inform what we're trying to do. So with that, I think as with any of these types of things, it's always good to level set on a definition. So I think we're going to have a definition, and then if you don't mind, maybe the panelists can make comment on it if they agree with it, if they have anything they would like to add, and maybe once we get the definition up, we'll start with Elena, please. So I'll read it off, and then we'll see how everybody feels about this as at least the foundational definition. So health equity means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health such as poverty, discrimination, and their consequences, including powerlessness, and lack of access to good jobs with fair pay, quality education, housing, safe environments, and healthcare. For the purposes of measurement, health equity means reducing and ultimately eliminating disparities in health and its determinants that adversely affect excluded or marginalized groups. So how is that as far as an opening definition for equity? Does anybody have any other?
I'll start. So at Episcopal Health Foundation, we use this definition. It was developed through the Robert Wood Johnson Foundation, and it's particularly resonant for us in philanthropy because we have this giant big problem that we're trying to solve. We didn't have a good definition of what was in it. And most importantly for us, we didn't have a good way of knowing if we were getting there, and how you actually operationalize a concept like health equity is really critical, because if you don't have a way to operationalize it and to measure your progress, then you don't know if you'll get there or not. And the part of this I like the best, well, two parts. First, the fact that there is measurement, because that allows us to operationalize. But also the first sentence is really critical, because it talks about everyone having a fair and just opportunity to be as healthy as possible. And I contrast that with what is really a myth in this country, and that is that if everybody works hard and plays by the rule, they have an equal chance of getting somewhere. And that's just not true, because everyone doesn't start from the same place. And this definition acknowledges that a child born into my family near Rice University fares very differently than a child born to a young single parent working two jobs in a very low income minority part of town.
Thank you. Jean or Zawadi, do you have anything you'd like to add to that, or how do you feel about that, the definition?
Sure. I think the one thing I would add is just the distinction between equality and equity. So I think equity shows an advancement of the field in how we think about this whole topic and social determinants of health. Whereas I think historically equity was just everyone was at the same level. I think this concept of equity shows that everyone may need different things, and it recognizes that. It recognizes the context of what may be unfair, unjust, and avoidable. And I think the classic schematic or picture that people look at is, you know, I can't show it to you now, but three children watching a baseball game, and they all have different heights. And so one child may need no blocks or nothing to stand on, and they can see the game fine. Another child may require one, another child may require two. And the concept of equality, they'd all just have one box. But you know, depending on their height, one of them may still not be able to see anything. With this advancement and this discussion around equity, you understand that different children may actually be different numbers of boxes, crates, whatever you want to call them, to actually be able to see the baseball game. So it really hones in back to that concept of opportunity. And I think it's just important to distinguish that from equality, because I think that's how we used to talk previously.
And I can't add any more to that. It was excellent.
Very good. All right, great. All right. So I think all of us have, you know, all of us being in the health field of health, we've seen reports, we've seen the news, we've seen data where there's large health disparities, especially between when you're comparing white populations and black populations, as well as other communities of color. For example, African Americans are twice as likely to die from heart disease. There's 50% more chance likely to have high blood pressure. And also, I think, you know, the part that it really caught me recently is the age. If you actually are able to take a person and see what the age of their body is, it's much more relatable to being 10 years older compared to a comparable maybe somebody in a white population. So with that, and if there's anything else you'd like to add, and obviously with COVID, these things have become exacerbated. So what are some of the factors that are driving these negative health outcomes? You know, actually we'll start with, I'll do roulette. Let's start with Jean, if you don't mind starting with that one.
Sure. And so, you know, there are a number of factors. It could be access to care, it could be poverty. I think also social determinants of health, which is obviously what we're talking about here. And I think to try to get into that example, I'll just give one quick study that came out in 2013, where they looked at just people who are on Medicare to look at differences between black and white in terms of whether they went for low quality hospitals or high quality hospitals, for surgical procedures. So in theory, they all had the same access. So you took that out of the equation. And what they found in that study is even though Blacks live closer to what were deemed high quality hospitals, they actually tended to go to low quality hospitals. And so it was this question of, wow, if based on mortality and morbidity, they should be going to this hospital because it's higher quality, why did they go to these, quote, lower quality hospitals? And I think when you think about it, it actually kind of gets into this whole context of social determinants of health, because it could be the referral pattern of their primary care provider. It could be that their historical experiences with these hospitals that are deemed high quality hospitals, they may not be high quality for them in terms of social services, food banks, interpreter services, other aspects of care that are relevant to them or their community. So I think, again, when you take into in concert all those different aspects of the social determinants, you can see where you can have a study like this on superficially, you say, these results are shocking, but then when you incorporate the social determinants of health, it actually starts to make some sense.
Zawadi or Elena, do you have anything you'd like to add to that? Go ahead.
Yes. So I'm so glad Jenny framed the entire conversation around health and not just healthcare. And I'm delighted to follow Jean talking about the inequities in healthcare and accessing, and also what happens when you actually do access healthcare. For me, COVID and the disparate impact was totally predictable. We knew this was coming. We knew because of the living conditions and community conditions and employment conditions and housing conditions of people of color that they were more likely to be exposed to the virus in the first place. So their prevalence was going to be higher. They are in jobs that they may not have paid time off. They live in housing conditions where they couldn't isolate if people were sick. They work in essential services, and so they had to show up at work, and their employers may or may not have had adequate precautions in place. And so it should have been expected that non-white populations would encounter the virus more than white populations. And then you add on to that people who have pre-existing chronic conditions like diabetes, obesity, hypertension, and heart disease are more likely to have serious complications and even death from COVID once they're exposed. And we know from decades of data that non-white populations are more likely to have those chronic pre-existing conditions. So they were set up to get the virus at higher rates and to have more intense complications if they did contract the virus. And the data has shown that, and a lot of people are paying attention to it, which is a good thing. But if you want to resolve that problem and you don't want that to repeat itself in the next disaster, pandemic, you name it, then you have to move upstream and address the conditions that set people up for failure when something bad comes along, because it'll come along again.
Zawadi, actually, I did have a question. This actually is kind of a combination, an intersection of what Jean and Elena have already talked about. I mean, I know it just from our experience, this is before the pandemic. This is early last year. You know, I'm not sure if anybody remembers the ITC fire, the explosion, the plant explosion. And if you looked at far east Harris County, the lack of health institutions, which then required a public health institution to be the healthcare resource to go out there. And we had, I think, over 1,000 patients in 3 days, which just kind of demonstrates how the conditions are. As far as like your clinics, I think you try to account for, I think, the living reality of some of the parents and so on. Can you explain something a little bit about how some of that, your clinic and how that works with healthcare and adjusting for employment and just the reality of childcare?
Yeah, so I think we're all feeling it now, at least those of us that are parents that are homeschooling now, but just being a parent, you're busy. And then on top of that, if you have other complications such as multiple jobs, if you're a single parent, or if you have lack of transportation. So our clinics are opened at night, weekends and holidays, primarily because, some people don't have the luxury of being able to take off from work and take their children to get seen by the doctor, or they get docked from work. They're hourly. They can't take PTO, or any other complications when you have a lot of barriers. And so one of the things that we do is we've been doing telemedicine for a couple of years now, and that's another convenience for parents to be able to have their children seen without having to plan transportation, plan childcare for the other children in the household. So one of the things that we try to focus on is how do we remove those barriers for children to be seen for busy parents. I'm a busy parent, but I also have the help of my husband and my community, and transportation, and I run my own company, so I have a flexible schedule, but I know that I'm super fortunate, and not everyone else has, not everyone has those conveniences. So how do we make sure that all parents, all children have access to, overcome those obstacles that they may have?
Good, very good. And I think Elena already touched on this a little bit, but if there's anything, if you have anything to add, I for whatever reason, with the pandemic and with obviously the tragedy that happened with George Floyd, there seems to have been some type of quantum leap with people's understanding what's going on. It seems like. Can y'all anybody comment on what you feel like may have been the reason behind that, or have you noticed that in your circles or people you've interacted with, as far as like you feel like people seem to the awareness has just increased drastically? What may be like some of the factors that have led to that?
I mean, I can start. I mean, I think part of it is just living in a pandemic where people's attention is much more focused because, whether we like it or not, our worlds have become much smaller in terms of other things to do. And so I think this whole attention towards racial justice comes at a perfect time in the sense that people are looking for meaning, people are looking for things to focus on during this time. And I think there's not a lot of distraction. I think that's my main point. And so it's an opportunity for people to really engage in a meaningful way and start to think about what these issues are. And then to start looking at the data as well that's coming out, because some of it's just so obvious in terms of what some of the inequities are. So I think we're just we have this great window where we have everyone's attention, again, not for good reasons. We're in the midst of a pandemic, but I think that helps towards getting people's attentions around these issues and hopefully using this window, because it will close, using this window to really make some advancement along the lines of not just research, but along the lines of healthcare, and to Elena's point, always around health. So moving beyond the walls of the institutions that I sit in.
Very good. Anybody else would like to add to that?
Yes, so I agree with everything that Jean said. One of the things that's different this time around, and this includes in the equity conversation, because the equity conversation is not new, but the word race and racism and racial discrimination is front and center, and it is one of the most significant social determinants of health. And typically when we talk about equity, we don't talk about race because it's difficult or impolite or whatever. We're past that now, and the country is actually engaging in a conversation, and I hope the window doesn't close too soon, where we're talking about race. This is not just differences between groups or equity. We're talking about Black people and brown people who do not have these same opportunities in life. And we built these systems, we can change these systems. And that to me is a hopeful and different turn on the equity conversation.
Great. That's actually a great segue to the next question. So I think some people have questions like, why are they specifically affected? Like, what are these, why are, so, I don't, they live day in, day out. They may not actually recognize and understand the history. So how have larger societal structures played a role in perpetuating racism and bias towards people of color, and also and how that plays into the healthcare system as well? So healthcare system and even beyond, what are some of these societal factors and maybe some of the history that may have led to some of these health and other types of disparities? Zawadi, would you like to start with that, or?
Yeah, I mean, I look at some things such as, you know, Black women are 3 to 4 times more likely to die from childbirth than our white counterparts. And I look at like, why is that? And I'm sure, Jean probably has great, research and data on that. But, anecdotally, when I speak to women of color, and across the spectrum socioeconomically, and it affects everyone, folks that have money, folks that don't have money. So you can kind of, take that off the table. It's not like women, Black women with access to care have don't have that issue. They do. I've talked to several women who, actresses, professionals, CEOs, and they all tell me these horror stories. So it's like, how is it that these women that have great caliber access to healthcare are still having these complications? And so it must be something systemic in, how, they're being heard, how they're listened to, the doctor referral patterns, what level of treatment, how soon it escalates if there's issues. So, just looking at, the research and the data and hearing anecdotally what's going on, these things have happened, where we just aren't being heard. We aren't being listened to when we go into the doctor's office. When we seek care, we don't get, a sense of urgency. And so I think those are some of the complications we really need to deal with. Whether it's, there's not enough people of color in medicine, but I don't think that should be the case. We shouldn't have to go to a Black doctor to get good access to care, or, for people to hear what we're saying. And so those are some of the things, like Elena said, it's uncomfortable conversations, but it's conversations we need to have, because, I should be able to walk into a healthcare clinic or a hospital and be seen by whomever and expect quality care by all the physicians, all the staff.
Jean, I'd like to, if you can add to that, and also I think to help people understand, because this is something that, and I'll be honest, in my years that I've been working in the health room, I'm still constantly learning, and to whatever extent, like you can inform us also the generational effect, the impact of having generations of people who've had to endure certain types of living conditions and these types of things. So if you don't mind adding to that as well.
Yeah, no, absolutely. So I think when I think about the lens of healthcare in terms of what it contributes to inequities, disparities, I go back in terms of history. So a couple of things. One is just in the area of diversity within the healthcare realm. In 1910, there was this report called the Flexner Report, which was this man who actually traveled the country trying to find the best model of medical care, medical education. And he went to all these different medical schools, and he determined sort of the Hopkins model was the best one. But in that time frame where he did this massive report, what he determined were certain medical schools didn't meet the quality that he thought was appropriate. So he ended up closing, I think if I remember correctly, it was 5 of 7 medical schools that were predominantly African-American. So if you think about just the lens of where diversity is now versus what it could have been, just that report itself, and it's an absolutely famous report, closed down 5 of 7 medical schools that could have contributed diversity. So that's one aspect in terms of where we're looking at diversity within the healthcare system is now. And you just see that since the 70s, there have been all these different programs, initiatives to improve the diversity in medicine. And it's actually remained flat, absolutely flat with respect to underrepresented minorities in medicine. So African-American, Latino. As of now, the numbers and percentages of African-American males in medicine as physicians is lower now than it was in 1978. So we've actually regressed in some ways. So that's the diversity piece. The other piece I want to talk about briefly is just medical mistrust. And so we talk about the Tuskegee experiments, where the US Public Health Service did all this research on the late effects of syphilis on African-American men, despite having penicillin as the treatment standard, just because they wanted to determine what the late effects were. And that continued from, if I remember correctly, the 40s to the 70s. So that's a big piece there in terms of medical mistrust. Another one which I think has gotten a lot more attention in the last decade, is the story of Henrietta Lacks, who is the woman who, without her knowledge or consent, they took her cancer cells and they became what are known as the HeLa cells, which are cells that have been used in so much medical and scientific research over the last at least 50, 60 years. And lots of money has been made on it, but she never even knew that her cells were being used. So when we look at COVID, when we look at all the history of what it is as underrepresented minority, Hispanic, African-American, to go into the healthcare system, this is the context that they go into the system with. This is the mistrust. This is the stories that their ancestors or family members have told them. And then on the other side, you have this shortage in diversity as well. And as Zawadi said, not everyone needs to have, an African-American or Hispanic provider. That can't be the answer. But it does contribute to other people's education and sort of in a complex system of healthcare of how people think about complex problems.
Oh, that's great. And also, if we look at the map of Harris County, and I'm sure across the country, there's certain places where you see the health disparities, and they happen to line up really well with certain races. And it's not that there's an inherent aspect to a person of color having certain health conditions. Elena, what are some of these things that may have set some of these people to these special communities of color to be living in some of these places that happen to be having, experiencing some of these health issues? I think, in the Harris Cares report, I think Episcopal Health had a map also, demonstrating the 24 years difference in life expectancy as well. So what are some of, maybe outside of the healthcare realm, what are some factors like, I'm aware redlining, but what are some of the other factors, or that if you want to actually kind of go into that a little bit more?
Yes. So one comment to follow Zawadi and Jean, who are in the healthcare sector. So the problems of racial discrimination in the healthcare sector are not unique to the healthcare sector. The healthcare sector is part of the American sector. And what they both talked about is a reflection of being part of a larger system where people who are not white simply are treated differently. And it goes back to the founding of this country. With respect to specifically what you're talking about, what I would frame in terms of the social determinants of health. So access to healthcare and the experience that non-white people have in the healthcare delivery system were unfortunately beautifully described by my two co-panelists. But even before people get to the healthcare system, Black and brown non-white populations are more likely to live in communities that have higher environmental problems. They are more likely to live in communities that are zoned to schools that are not as good as other schools. They predominantly, or more predominantly than white populations, have lower incomes for their household. And all of those things in combination, along with the stress of being a victim of discrimination, put people in a position to not be as healthy as someone who lives in a different part of town with a different income level, different educational and working opportunities. And if you're living in those circumstances, particularly when they accumulate and they pile up, so it's not just that you live near an air pollution source, it's also that you don't have a good school and that you're in crowded substandard housing. When you aggregate all of that, you have people whose circumstances conspire against their health. And so they can want the best, they can behave in the very best way, but their circumstances are making them less healthy. And so they will have a greater need for health care. They will likely have less access to health care because they're more likely to be uninsured. And once they do get to the healthcare delivery system, they face the kinds of obstacles that Zawadi and Jean talked about. And so it's playing behind the 8 ball from the very beginning of life. And those are larger social and economic and societal conditions that we can address if we're willing to talk directly about the issue and not fool ourselves into thinking, well, everybody who works hard can get somewhere.
And
using a model minority to say, well, see, this person did, look, Zawadi and Jean made it, so see, there's not an issue. That's not true. And we've got to be able to have that conversation that they may have been exceptional. You shouldn't have to be exceptional to have a fair opportunity in life.
Very good. And y'all painted a great picture from looking historically up to now. I think it's really appreciated. So we have a couple of questions, and we have a little bit of time. So let's start off with what's the greatest challenges. So what are the greatest barriers to health and racial equity in the Houston-Harris County area? And after that, we'll kind of get some advice from the three of you as to what can be done at various levels. So let's start off with the challenge. What is the greatest, if you want to list a couple challenges or barriers? Let's start with Jean. I would like to start with him just to make him uncomfortable.
I love that. Yeah, I just expect it from you. I'll get you back later. Don't worry about it. So I think there are times where we can make it really complicated, and to some extent it is complicated. But I think for me it does come down to these very basic issues of poverty. I think poverty is such a big thing. It impacts so many other areas in terms of just, it's transportation, it's childcare, it's ability to access the healthcare system, it's stress that it causes someone to feel. And so, they've done studies where you look at stress levels among people living in poverty, they're going to be higher. And that stress level can affect you physiologically in terms of just high blood pressure, heart disease, all these other areas. And so I think, again, there are so many factors, but I think you can actually start with a few of them and just understand that it's sort of this cascading effect on so many other areas of the social determinants.
I want to pick on it. One of the particulars you mentioned, you'd mentioned the effect. So just, again, I don't know where the studies are on this. So let's say if a mother's pregnant and she lives in a stressful situation, will that have an effect on the baby? Or is that something that we know, like how, if somebody lives in a very toxic or stressful environment, what type of effects may that have on a baby? If you don't mind me adding.
Yeah, that's a good question. I don't want to say because I don't know exactly where the research is, but I do know people have had studies where what they do is they measure the cortisol levels, which is a marker of just stress in the body.
Sure.
And just to see what that is. And then they try to see if there's some kind of relationship between those levels and, specific outcomes for the mom or the baby as well. So I know those studies are probably out there, but I just don't know the results.
No, that's great. I think it's just good for people to understand like all the different levels of how these things can, like Elena said, just kind of layer on top of one another.
Exactly.
Yeah, Zawadi, would you like to go? It's like, what do you feel like is the greatest barrier or challenge to health and racial equity?
I think, Jean just said it, poverty, and what all that brings to it. It's overlapping, like Elena said. It's insurmountable. I was listening to a radio show during the beginning of the pandemic, and the gentleman recommended that we all, take a break, take a walk, in our gardens and meditate and, do self-care. And he just got pummeled in with all the callers saying a break, garden, like meditate, like I'm looking for food, I'm scrounging for, where I'm going to live, and so, I think a lot of times, even we call it, you would think the guy was saying his basics, for me to self-care, I need to center myself and, have a restful place. And it's like, callers are like, if we're looking for our basics, just the basic level of food, housing, shelter, then we don't have time for walking through the gardens. So, I think when it comes to health, we have to really think about that. There's a lot of people dealing with just getting the fundamentals, just the basics of survival. And then all these other things you can add to it, but, we got to get people up to the level of like they're functioning. And I think that's the biggest barrier.
Thank you. That's great. Elena, what do you feel like is the greatest barrier, challenge, or challenges?
I think it is the mindset of white people. and the belief that life is a zero-sum game. And so if someone else gets an advantage, it means I'm disadvantaged, and I don't see life as a zero-sum game. But sometimes the way the conversation unfolds, it makes white people very defensive and feeling like they're going to lose something. And I think that's a long-standing barrier, and that there are opportunities for white people to learn about racial justice in a way that is not threatening and doesn't make you feel like you're being attacked because you're a bad person. And I'm seeing an increasing amount of resources available publicly and privately that help white people learn about this, and learn in a way that we can appreciate and get your head around without feeling threatened or defensive, or where you have to say all the time, well, I'm not a racist. And I think the more that those conversations happen, and the more that individuals, families, organizations learn how to have these difficult conversations, the more willing we will all be to change the structures by recognizing the inequities, and that we can fix them, and I'm not going to lose anything because of it. Or if I'm losing something, it's because I had an unfair advantage in the first place. And those are hard things to learn. And it's a journey I'm going through myself, and our organization is going through. But I feel like that is a huge barrier when you look at these conversations as us versus them, who's going to get what I have. And you don't have to do that.
There you go. You open up another couple semester topic there, Elena. That's really good. And we have just a couple of minutes. And so but to the best of your abilities, we don't want to just leave it. We want to give the people who are watching and who are listening and participating, give them something that they can work with. So if somebody is working, and I'm just going to give all three levels, and you can speak to whatever you feel is most comfortable. If I have the ability to work at a policy advocacy level, what can I do? If I work at an organizational level, what can I do? Or if I'm just a person in my office, or I'm a parent at home, what can I do? So what are some things that you can give somebody, something to equip them to help them contribute to be able to address some of the things we've discussed here? And I was also, you know what, I'll start with Zawadi this time. I'll let you off the hook. Yeah.
Well, I'm going to come from this is probably a business community that we're talking to, and I'm an entrepreneur. And so one of the things I want to challenge the business community is, we're in Houston. We're a city of entrepreneurs. We're a city of innovation. I challenge us to look at these problems as business problems. A lot of times we, put this on the government or the nonprofits or philanthropy. And I really think that, we can come at this, solve problems through innovation. And not, that's why social entrepreneurship is really, really popular now, because people want to bring innovation to this space. And I would just challenge, us in the business community to make room to find sources of funding. Maybe there's some private equity out there that you guys are, some patient private equity that's interested in solving these problems. And I think that's how we're going to solve a lot of them, is that, we have private enterprise involved, or partnerships, public-private partnerships to solve some of these problems. Like for us with, extending the number of hours and days that you can be seen by a doctor instead of having to go to the emergency room. So there's really a lot of things we can do if we bring entrepreneurship into it, I think. Great.
Thank you very much. Gene?
Sure, I would add to that is to overall, just really to see the long game in this. And in the sense that I feel like, when things happen with George Floyd, other issues around disparities within COVID, I feel like so many people want to do these very quick interventions. Let's write a statement. Let's just come up with a quick program that we're going to start tomorrow. And let's throw money at it, the first chance we get. And, just from our conversation, I think everyone could, agree in the last however long we've been talking, there's so much more to this. And so I'd say the first thing is just to don't look for the easy fix. And then two, I would say is, to Elena's point, be willing to live in some discomfort for a little bit, because that's where the true solutions, and as Zawadi says, the innovative strategies come from. It's not just trying to sort of get it off your plate so everyone can feel better and you could feel like you've been accountable. It's really living in that discomfort. And I think that's all of us, whether, you're white, brown, black, whatever. I think it's living in that discomfort and having those difficult conversations, then looking within your organization and saying, we're asking, what are the policies and procedures that sort of perpetuate inequities within our organization? We don't think there are any, but let's just assume that there could be. And let's actually look at all of them. So really go in depth into what those are. And, just having been involved in some of those, those strategies in different organizations that I'm a part of, you actually uncover a number of areas where you could actually make some substantial change. And you learn about things that you hadn't even known about. So again, it's really, don't go quick, live in discomfort, and then look within yourself before you start projecting strategies to everyone else.
Very good. All right, Elena, just to make sure people have time to answer, I'm going to give you 60 to 90 seconds to solve the world's problems.
That's easy. I'll piggyback on Zawadi about the business community, and I'm going to channel some Steve Kleinberg. If we don't maximize the opportunity for all of us, we're missing out as a community as a whole. It is not a zero-sum game. We could all have more if we really tap the resources that are available in all people.
Very good. That's great. Thank you all very much. So I think that is the end of the panel discussion. I think we're about to switch to the Q&A session. Is that right?
Yeah, great. Thanks. So as many of you all have done, if you have questions for the panelists, please go ahead and submit them at the Q&A button at the bottom of your screen. And I'm actually going to group some of these together. Let's start kind of, if we were to rewind the tape 30 minutes, right? And I think some of the questions here, and I'll say, I'm not understanding the disparities, inequities, discriminatory practices. As a taxpayer and a colored person, I have the same access. If you pay, they will take you. There's a similar, somewhat related question, based on what Zawadi said, isn't this more of a poverty issue? Don't poor Hispanics, whites, and Asians have the same inflated health issues? And so I'm thinking through how to answer that, and we didn't get to this part yet, but Zawadi, what I think part of what drove you to open the NightLight Pediatric Urgent Care Clinics answers some of that, but I also don't want to answer for you, but I would love to hear kind of your perspective on it, and then the other panelists as well.
And this is which question?
It's it's basically the combination of if it is poverty, then what is that element of race, right? If I'm a taxpayer and I can pay my hospital bill, why is there any disparity, particularly based on race, for the kind of care I would be receiving?
Yeah, so I do believe it is fundamentally a poverty issue. So, not sure if it's, the correlation with race as well. I'm sure there's some components there as well, but it is fundamentally a poverty issue. Lack of access, and other issues that complicate your life and your matters. And so for me, I think we have to make it to where, like, this conversation of equity, to where, regardless of what color, socioeconomic status, we all have the same ability to have the same level of health. And so I think the challenge before all of us is to challenge our assumptions. I live in a zip code where it is very diverse. I live in 3rd Ward, And I wouldn't send my child to the school in my zip code, unfortunately. And so I think that's awful. And so I think that is, all children should be able to walk to school like I did as a child. And the school should be awesome for all children. And so I think we all, you know, we have to, as taxpayers, as people who want a greater society, as Elena said, it needs to be great for all of us. So we have to address the fact that some people are poor and don't have that same access to health.
Can I just add to that is just that, you know, my lens is as a clinician, but also as a researcher. And I appreciate the question because I do think that's where a lot of cynicism around inequities and disparities come from, because people say, well, isn't it just all poverty? And so there's been a lot of research done towards that end. And even when you factor in poverty, the disparities may decrease, they don't go away. And I've looked at tons of studies, they do not go away. So poverty is obviously part of it, but it's not the whole thing. And then there's been another sort of field of research where people actually take these clinical vignettes, meaning they give these case scenarios like you would do in any other profession, and do this research where all they change is the person's race, ethnicity, or gender. And the physician's recommendations on doing actually the standard of care, the right thing, actually differs. And so when you take that data and you say, hey, we basically had this controlled environment, gave these clinicians a little vignette to read this case scenario, here's what their clinical history is, what would you do? It differs, just based on race and ethnicity when you've controlled for everything else. And so I think it's that combination of research that shows that poverty doesn't take away all the disparities. And then also this other field of research that shows that even when we're able to control these things in these little case scenarios, something's going on. And so again, I think it's all together. And so I think sometimes we want to find one answer, and there just isn't one answer, is what I'd like to put out there.
And can I add just one more to that, if you don't mind? And also I think the question is good. And also, yeah, there's an understanding of, there's an individual reality, and then there's the reality that occurs to a population in certain places. So I think if you kind of put together all the things that the panelists had discussed across the thing, the picture is, you know, if you have especially a specific in different communities, but especially the Black population here in the United States, if you know, I think the concept of redlining, where there was government policies and private policies that put certain community colors, did not allow them to live in certain places, and you put them in certain places that are outside of where opportunities are, and then compound that with, over a period of time, those houses do not accumulate asset wealth. And you also other types of policies related to how hundreds of millions of dollars were taken out of Black farmers' pockets. So if you look over generations, that much wealth not being is being taken out compared to other ones. And if you look at how wealth is, you know, wealth is by people who work hard. That's one way. There's also money is passed down. There's an accumulation. So if you look at a population level, and people are then put in certain places where there's not opportunities, where the education is not maybe as robust in certain places, it has these effects on health over a generational period. And then you can see how, in terms of population in certain areas, their health is going to be affected in a really noticeable fashion compared to other ones that maybe have grown up in a place where there's more opportunities, and those things have not been taken out of the community as well. So, and that does affect the pipeline. It's kind of like what we've discussed. You know, if you live in a place where the education is maybe not, I mean, I think there's a lot of talented people, but if you look in it, you know, money does help increase, attract teachers. It helps, you know, it helps with the students in terms of the resources. But the pipeline for people to become an engineer and doctor, these things are affected. So it's a historical, it's a reality of various factors that have led up to what we are now. But that does not take away the individual reality of many people's success as well. So that's there too.
You know, there's a lot of questions that are centering around how we ended the moderated section, which is what can be done. But I think that there's, you know, some that are honing in. So Greg is asking, you know, what initiatives, if any, have produced improvements in one or more dimensions of health among populations that have experienced discrimination for generations. And another way to look at it too, and how they're asking, you know, what are those best real life examples? or small shifts that can impact these structures that are in place. And then so is it, diversity training, implicit bias training? What have you guys seen that works? And then there's also questions that are about, what is it in Houston specifically that can be done as well? So really kind of a solutions-oriented question, highlighting successes of what's worked. Elena, I'll start with you since.
Well, I'll start with a plug for Houston because we now have the new University of Houston Medical School, which is devoted to primary care, particularly for underrepresented populations. And their new class, I'm not going to get the statistic right, but they have their entering class this year, and they have a phenomenal number, really a majority of first generation students, people of color. And so they are going to be contributing, I think, significantly to the healthcare providers in our community. And I think that will work wonders for the community. I hope they all stay here and don't, become orthopedists in New York. But they're selected for people who want to work in these kinds of communities. I guess I'm going to fall back on the work that white people need to do. And it's probably there because that's where I am right now, because that's the work that I need to do and that we're doing within our organization to get past defensiveness so that you can actually do something. If you look at the data that both Zawadi and Jean talked about, particularly around Black women and maternal health outcomes, you can control for economics and you still have huge disparities. And if you can start with a little something like that, not that it's a small problem, but where you really hone in on a particular population and you try to make change for that population, I think you have a chance to do that. There's a program within Houston that is called Healthy Houston Women that has brought together a lot of different actors to really try to create a continuum of care for Black women before, during, and postpartum so that these kinds of outcomes don't happen. And if you can be successful in something like that and you can see that you can close a racial or ethnic gap by attending to it, my hope is that then you say, okay, if we did it here, we can do it there.
I forgot to ask this earlier, but this is actually a good time. The book recommendations, because again, we're going to be able to answer all the questions to the extent that we should. What are the book recommendations, if you could give like one or two for the audience to maybe check out, if you had recommended a book or two? Jean.
Well, I think one, again, I just think historically, one is Unequal Treatment, was something that was put out by the Surgeon General, David Satcher. I think it was in 2003, that really just documented all these issues around health inequities. And it was just a big and important document just from the federal government.
Zawadi?
Yeah, so I just finished a book called Well, W-E-L-L by Sandro Galeo, physician out of Boston, and it's been amazing. It talks about kind of the root causes, like we've been talking about, the full extension of health from education to politics, power, health, healthcare, the greater society good it will do if all of us have the same access to health. So I highly recommend that book.
All right, Elena.
I just finished reading Caste, C-A-S-T-E, by Isabel Wilkerson, and she does a study of Blacks in America, Jews in Nazi Germany, and the Dalit caste in India, and shows the parallels of societies that order people from who's at the top to who's at the bottom, and the desire of everybody to want someone to be below them. So even the lowest groups find distinctions among themselves. And It was a great read because she tells a lot of stories. It's not a lot of data. It's more about stories of things that have happened to people. And when you read through it, it makes no sense to you. And so I found it one of those sort of gentle and welcoming ways to get into that discussion without feeling defensive and responsible for, 400 years of slavery when my family wasn't in this country. You just don't have to go there.
And sorry about that, Jen. I apologize for interrupting the flow of the question. So
no problem. Do you want to share one?
Well, you know what? I'm sure there are kids out there. You should read X-Men, because that is supposed to be a symbolic. No, I'm actually, to be honest, I just finished reading actually several books. I was like New Jim Crow. I think that was very impactful on me several years ago. And then How to Be Anti-Racist. I've read through that. I'm still want to digest some of it. There's some things, a couple of micro points I'd like to look into a bit more, may push back on. But overall, I thought that was it made me think a lot on a few different levels and layers, and had it made me think about myself. So those are a couple of recommendations. But I'll start with the X-Men.
Yeah. Well, I'll bet Jean liked that I flipped the question back on you in a way that you were not prepared for. Let's end on this one, and it's something that we had brought up in our prep call, which is some cities, I believe, Cleveland, had declared racism as a public health crisis, you had mentioned Harris County as well had done that. There's kind of an issue of making that statement, but then also devoting resources to it, right? And so if we were to finish on that question of like, to really move the needle on this, like where would you, if you could be king for the day, right? Dedicate that resource to, if we were to declare racism a public health crisis, right? But actually being able to address it in a meaningful way. So Tan, I'll start with you, and we'll circle around and end on that.
At the heart of it, I think there's, it's already been mentioned, poverty, but, to address poverty, employment and education are key. And so I would start there because, if you're in a neighborhood where the resources aren't there and it's just difficult for a student to concentrate, you have to create the beginning of the pipeline to then help empower people to then be able to get the opportunity, as Gina mentioned, to have gainful employment. And then in addition, there's a lot of which are good and well-intentioned. I think they're important, bias training, these types of things. But those same organizations also need to demonstrate that when there's people who deserve to be moved up and they are of different colors, that needs to be reflected. Again, as long as the people are there. So you have to start with the beginning of the pipeline and continue to move onward. And the private side really has, I think everybody's been impressing on that. There's a lot of opportunity there. And then that's one, I think, a way that we can so investment in education and investment in employment opportunities.
Zawadi?
I agree with that. I think there's certain things that we can do, big wins. I think from a business standpoint, you want to return on your investment, and we need to focus on those areas where we have a huge return on investment, such as early childcare education. I mean, it's been proven, I don't know how many research and data points that show, like, when you invest in a child early, then the likelihood of them matriculating through school is so much significantly higher, and it avoids, that third grade to prison pipeline. So, let's look at the areas where we have the greatest amount of bang or impact. And let's focus on those areas. And, through research, we know where a lot of those are, the example I gave as far as early childhood education. Make sure everybody has preschool. Everybody should be able to have preschool.
Thank you, Zawadi. Elena?
So if we believe racism is a public health problem, then we ought to take a public health approach to it, which to me means moving upstream. We've got problems in healthcare access and delivery, but if we really wanted to move upstream, we do what these other two panelists have been talking about, and that's that you would support families and education and jobs in communities, because that is how you level the playing field. The healthcare sector, access to it, and what happens to you in it are a reflection of whether you've done the upstream work or not. And so I would take the public health approach and move it all upstream, shift dollars upstream.
Thanks. Dr. Raphael, last words?
Yeah, so I agree with Elena. You know, I think by the time you get to the healthcare system, you're talking about it more as a consequence as opposed to a cause. And I think so we just have to reorient ourselves in terms of how we think about it. The other thing I would just add is just really think about things that truly at the local level, because if you think about these big problems and we're trying to make massive systemic change, that's important. But I think sometimes it just, if you go to a local level, you can tailor a lot more at the level of a neighborhood in terms of what's the community, what's the culture, what's the language, and really being able to see a defined change within that. And then once you go from there, you can replicate what you've done in other areas, again, tailoring to what those needs. So again, it's moving upstream, thinking about all these things that are evidence-based to actually help.
Well, thank you all today for participating in the webinar. This has been recorded, will be posted for everybody to rewatch or share or catch later. Next week, we do have a webinar focusing on developing equitable communities. And this is where we look at, the conversation around health, the conversation around education, but beyond that, we can look at, transportation systems, et cetera. But what has created some of the inequities and disparities in the communities around Houston and other, metropolitan areas, and what can be done to resolve that. So we hope that you'll be able to join us next week. And then our last webinar on September 29th will be focusing on the business community's role and responsibility in addressing racial equity. So wrapping up all of the conversations we've had for those 4 weeks leading into it, and thinking about sort of that action-oriented step. So thanks everyone for joining. Thank you again to the panelists and Tan for moderating. Have a great rest of your day.
You too. Thank you for again to invite us to this great discussion. Thank you. It was great.
Thank you.
Very welcome. Thank you all.